Hello everyone and welcome to episode 2 of our video chat. I don't even know really what we call it. Like, is it a vidcast or vodcast? Vlog? I don't know. But either way, we made it through the first one. So we're not going to make any mistakes. We'll be clean, perfect episode. So we thought that we might actually struggle to get content to put stuff out fairly frequently, just based on how much current affairs stuff there is relating to radiology out there. But actually, there's a lot that's happened since we last recorded, so plenty to talk about, so that's good for us. But I think first and foremost, just want to say a massive congratulations to Mohammed Khan, FRCR.
Yes.
Finally.
Passed the 2B exam.
Finally. Now pay me back, RCR. Pay me back.
So how does it feel now? You've conquered the 2B.
I'm relieved. Like, there's something really liberating about waking up and not worrying about an exam several months from now. Like, you don't have to wake up and be like, okay, I need to set time to revise this for this exam, which you may or may not pass. That's been one of the big, like, feelings. Like, just waking up and being like, you know, like the Stoic, I'm in the moment. Like, I'm living for today. I am now living for this podcast type of thing. But I think it's just been good because the thing is, you can now just focus on your training. That's it. That's the only thing left. And not having exams, I think, really helps the consultants. I've noticed that shift in perception where the consultants like, okay, you're now post 2B. We're going to treat you like a consultant, so step up to what you're going to be in like 1.5 years time. So that's been really nice. But it wasn't all plain sailing. Of course, I had my 2A mishaps, which we can save for another podcast, another life coaching session by RadCast service coming out soon. Peaks and troughs by RadCast et al. But in terms of... Yeah, that's trademark, by the way. Don't steal any. But it's more the exams itself wasn't as plain sailing as I thought they would be. Not from a revision perspective, but it kind of went like it went down on the day, like things messing up, things not working, results getting delayed, GMC getting involved. Like, you could write like a film on this, a biopic of the 2B July sitting. And of course, hush hush in the background is these forthcoming changes to the 2B, which I'm not even sure we're allowed to disclose. I think we are because everyone seems to kind of know about it. It just hasn't been confirmed by GMC.
I mean, there is public information out about sort of the proposed changes, so I don't think it's a secret. They asked people to volunteer for a pilot, basically, of this new format, which is quite interesting. I think they're going to get rid of the rapids and then replace it with a similar image interpretation exam, but it's going to be a bit more sort of clinical, asking you to provide some management advice as well as just like spotting the abnormality. So it's interesting.
I did the pilots. I did the pilots, I did the pilot because I was like, you know what, I don't know if that's going to be me, because everyone at that time, people that we did Vivas with, were like, oh, it's coming in January. We got an email a few days ago from the exams lead saying it's not going to be January because we still haven't got it confirmed from GMC, but we're now giving you a 6-month run up. Like, we've now told you, the cat's out of the bag. It's going to happen. We've given you 6 months. So now it's fair game that after January, it's going to change. And the best way
is January the next sitting?
No, so we got one September sitting coming in 2024. Exactly. But then everyone that we were doing Vivas with was kind of like, it's January now. That's when it's going to change. But now I think the RCR have said the month of July, the 7th month, we've now given you a 6-month warning that it's coming. So don't be like, oh, you can't change it. You haven't given enough warning. It's kind of like, get ready. So I think January is going to be the last current format sitting. And then it's going to be from March 2025 onwards, potentially, the new sitting. But having done the pilot, I think the best way I can like describe it, think of longs for plain films. That's really it. It's
that's kind of the
rather,
impression that I got from it as well. From seeing
because I shared the like I showed you guys the PDF that we got, and the questions did test your ability to interpret a plain film. But the thing is, every plain film has an abnormality, like all of them. 25 plain films, all with an abnormality. So it's not like, oh, can you spot it? Can you not spot it? You've been told they have something. And I remember when I did the pilot, there was one facial X-ray, and on first review, I didn't see it. Like, I didn't see anything wrong. But because I knew there was something there, I just kept looking. And then eventually it was a very like subtle mandibular fracture. But because you know they're all abnormal, you will find it eventually. You just have to keep looking. But I think the interesting thing was that they're now integrating elements of the lungs, like your report, specifically the management, which I think will potentially even throw both UK graduates, well, UK trainees and international trainees, because it's a bit odd. Yeah, fair enough if there's like a lung tumor, you know, to escalate and 2-week wait, all this stuff. But like fracture clinics and stuff, I don't know about you guys, but whenever you ever put in your report, referral to fracture clinic is advised.
But maybe we should be doing that, and this will sort of be priming people to report in a way where you actually give advice rather than just give
a generic description.
I'm not sure I'm in favour of that idea of them all being positive, because it's just like a good thing about a good radiologist is able to sort of dismiss cases as well, not just find positive findings, but know when it's okay to say something's normal. So if you're encouraging people to be looking for pathology in every case, I'm not sure that's necessarily, it's going to lead to overcalling essentially. I think the Rapids was good because it did punish overcalling.
Yeah, particularly like plain films as well, where the vast majority of them are actually normal.
Yeah, I'm not sure about that. I mean, the Rapids gets a lot of hate, but I think as a sort of a very cutthroat exam, I think it works. Like 30 minutes, and then it's just you and those films, and it's make or break basically. You can get 8 in your 2Bs basically pass, or you can get a 5 and you basically failed. But I did like that high stakes element to it. I don't know. This one's 2 hours. This new format.
So they've said 2 hours and 25 minutes, but of course. It didn't take me that long to go through them.
Right, okay.
We haven't got feedback from it, so I don't know whether I got all of them wrong. And but the thing that the reason for their justification was like, oh, the dynamics of plain film reporting have changed since the Rapids were kind of introduced into the 2B. We're trying to like ensure reports of an equal like quality across trainees. And then I think the third one was, in the current Rapid format, there's a lot of emphasis on peripherals, like peripheries, whereas the pilot ISAT had a good balance of like chest X-rays and peripheral limbs. There was a few abdominal X-rays, but it kind of balanced it in the sense that there was a lot more chest X-rays than in the typical Rapid packets that you get. But like I said, I think the key thing for anyone listening is it's coming. It's no longer, oh, we're thinking of doing this. It's up to the stage of GMC just needing to give them their blessings, dot the I's and cross the T's. Once GMC have approved it as a exit exam, as like a component of the exit exam, then I think the RCR have kind of told everyone after January 2025, this is going to be the replacement of the Rapids.
It doesn't sound as bad as when they changed the 2A and there was those guys who were doing the modular format, and then if they hadn't completed all the 6 modules by the crossover time, they then had to switch on to doing the big exam split into 2 papers. Like the way you revise is going to be broadly the same, isn't it? Like you still have to get through a good volume of films because your spotting still has to be up there, but then it's just what you're putting on the paper that's different. But then the way you practice for the long cases kind of covers you for that style of work anyway.
Yeah, it's just what resources they'll give candidates. Because if you look at the current platform for the RCR 2B, there's not much like resources. It just tells you this is the structure for the 3 components. this is what we expect. I think they give you one example of what a case could be in the Viva. I think it's like a sickle cell abdominal X-ray where you see the H-shaped vertebra. But apart from that, that's it. So I think it's more of a case of candidates now getting really stressed about how to prep, because the consultants will be like, well, we don't just report more plain films, but it's more of a case of, I think, personally being aware of guidelines, especially for like plain film related modalities. Like if you see this on a plain film, you should be recommending X, recommending Y. I personally think they've added extra work to themselves.
It's going to be harder to mark, harder to standardize. There'll be a lot more variation in what a correct answer will be. So it does seem like more work for them.
I just thought it was extra work because with the current rapids, it's very like normal, abnormal. Normal, it's normal to R2. If it's abnormal, you said the correct pathology, bam, you got the full marks. And in the sitting I had, they actually had to remove questions post-exam because of quality control issues. So I'm just thinking, like, if that's now in the case of several small longs in the plain films, it's just there's going to be so much variation how people report, that how they standardize and how they make an ideal report is just adding workload. But we'll see. It's just that I think if you aren't aware of this, potentially people who are getting ready for the 2A now and then have their 2B afterwards, just know that this is going to be most likely the way you will sit. You'll have the longs, Viva, and now this, I think they call it short plain film reporting, which is going to replace the rapids.
Presumably this is all the talk amongst you guys who are still sort of in the midst of the exams, because the first I heard of it was when you dropped it in the WhatsApp group, but it's not really something that's been well publicised.
No, I think the reason it scared the bejesus out of me is because you don't want to be in that loop. It's what Jamie said before. The people who had modular 2A and then the synoptic 2A, they got caught in like the Netherlands. Like the
I mean, imagine having 5 modules, and then you have to do the whole thing.
And time's ticking, and you're like, all right, I've got one attempt to get through these all. And the problem is, like, fair enough if we were in medical school and exam is the be all and end all, but you're also trying to do your training, and you're then having teaching sessions which take you away from training, and it eats into your time. Because you've got to still get those levels for your ARCP, and you can't be like, oh, I was preparing for my exam. They'll be like, yeah, you're meant to do that in tandem. So it's kind of, it puts an X on your back, and you're like now watching that hourglass, and every attempt is eating into it. So it's not like a case you got now 6 attempts at the new format. It will be 6 attempts in total. So if you've already eaten in to the current format, and then you jump into a new format where you have less resources for a critical component that you still have to pass, otherwise it could screw you over for the rest of the things. It just adds pressure where really it shouldn't be this high stakes, in my opinion. One thing that they've also said that they're going to do alongside this change is they're going to split the exam into 2 elements. So one is short reporting with the longs, and then the Viva, and you can pass components separately. So, for example, if you've passed the Viva, but the thing is, what is a pass? A pass is 6 out of 8, all right? So you can bank that and then be like, I'm going to reattempt. I think the reason for that is logistics, because every candidate that fails, regardless of whether it's longs, rapids, or Viva, they have to go through all of it again. And I really respect the examiners giving the time to go through so many candidates, but I just don't think it's feasible long term. So I think they've said, okay, you can bank those marks. That means you don't have to do the Viva again. So we don't have to put so much pressure on the examiners, but go and do your... So that's quite good that you can park, but remember a pass is 6. So would you want to still try again to get 6.5, 7? So we'll see how it works in reality, probably from March 2025 sitting onwards.
Do you reckon the prospect of AI on the horizon has had any influence on this sort of decision to change the format? Because just the concept of spotting abnormalities on an X-ray now, maybe going into the future, that may be less important for radiologists, because we may be assisted. So it's more about the actual interpretation of the images and the management suggestions on top of that.
For me,
is an exam that's more fit for... I think that's how they can disguise it as, like, you know, keeping up with the times, as it were. You know, changing the exam because the rapids has been around for ages and technology's moved on, the way we work has moved on.
I personally think it comes down to this, this emphasis we have being clinical radiologists. Like, I think it generally comes down to that. I think there's a bit of like a stick up your backside when it comes to being a clinical radiologist. You don't want to just be a radiologist. You don't want to just describe things. That's not what we do. You always have to put in the clinical context. I think, of course, the way we report plain films, especially since just starting training, has changed quite a lot. We've now got an increasing number of reporting radiographers coming through, sharing the workload. We will come to physician associates slowly. Just bear with us. We'll
just building up to that one.
Yeah, we'll get building up to that one. But dropping, like they say, you should give like a little early warning shot. That's coming, PAs. But I think it's the emphasis that you're meant to be a clinical radiologist. You don't just go fracture. We kind of do, but they don't want that. They want you to be like, no, referral to fracture clinic, referral to 2-week wait, CT is advised, CT abdomen and pelvis is now advised, portal venous phase, all this kind of stuff. Just to make the rapid reporting more clinical than it currently is. But I think the takeaway from this section of the podcast is just be aware it's coming. It just needs the final seal of approval from GMC. But I think based upon the email RCR recently sent this week, they've kind of said, it's happening. We've given you early warning now. We've given you plenty of runway to get ready for this. TPDs, educational supervisors, get ready for this new format. And start, if you know you're going to be sitting the 2B in 2025, start to try and change how you approach rapids. Start to look at more complicated plain films, for example, like bone lesions and how you'd deal with that. Because I can see a very easy case of a do not touch bone lesion and people saying MRI, people saying go for CT when you don't need to. Okay, it's a do not touch lesion. Similarly, start to get good with your guidelines, especially those of our international colleagues. For example, knowing 2-week wait rules, respiratory referral, etc., etc. Because I think those are the type of differentiator questions that they'll throw in, because they're very easy. And they do have a bank of these. They do have a bank of these from their rapids. So they can throw in a bone lesion that they've saved from, like, God knows when rapids and be like, yeah, do you know, by the way, this is a do not touch lesion.
Nice gems there. It sounds like you could maybe do a course for this, Mohammed.
And moving on
it is inevitable. It is inevitable that message will come through.
If anyone want to partner with us and help
when
us
we have downtime.
Yeah,
I wish I knew what downtime was. But moving forward, as we briefly alluded to, the topic of physician associates. It's been in the news. If you are very focused on medical news in the past, it's been getting more and more fanfare, and what we can, as politely put, it may have reached a boiling point in the last couple of weeks, if not months. It's kind of now reached a stage where people are now setting their lines, their boundaries, in the sense that, okay, this is what we deem acceptable for physician associates as a workforce to do. This is where we think it is a bit of a grey area. We know the British Medical Association have come out with several statements saying in primary general practice, primary care, it should be this. In terms of supervising physician associates, it should be that. Looking back, radiology is kind of being watching from the sidelines, but there has been cases of physician associates within interventional radiology. I've not heard of any in diagnostic radiology, but there have been cases, especially on the Med Twitter, where people have come out talking about physician associates being specifically within IR. But it is crazy to think that there's like within like health, like medicine, where it's quite important that there are regulations and rules and standardizations in place, that there has just been new workforce that have just kind of exploded in terms of their scope, in terms of their reach, in terms of their impact, and without any real definitive scopes of practice, like this is the red line, this is what we accept, this is where it's a no-no. Like I said, radiology's kind of been watching from the sidelines. How that changes, I'm not sure. Have you guys experienced any interactions with PAs? Like referring, requests, that kind of stuff?
Yeah, referrals.
Go on, yeah, you go first, Easy. You go first.
No, I mean, we do get referrals. Different people have different levels of tolerance for this and have different degrees of sort of how opinionated they are. You do hear a lot of anecdotal stories about really bad requests from physicians associates and not really knowing what they're sort of the imaging they're requesting and so on. Personally, I can't think of any like really bad interactions I've had. I kind of feel like a lot of them are just doing their job and are kind of caught in the middle of this medical sort of culture war, as it were. So I try to be as accommodating as possible. Obviously, if someone sounds like they have no idea what they're doing, then I would say, yeah, can I speak to a doctor, please? But most of the time they're fine, and I do think that it is interesting, like when you read the clinical notes or you listen to some of the consultants talking about physicians associates. I think a lot of and maybe this is where the issue comes from the trainee doctors, but it seems like the consultants do give them a lot of responsibility, actually value their input, and do get them to do a lot of roles that juniors would be doing. So, I mean, I've seen clinic letters when I'm doing my reporting as a good radiologist, going through the clinical notes and trying to clinically correlate. I've seen like whole clinical letters drafted by physicians associates, and it's like this is almost as if it's written by a registrar seeing this patient in clinic, and they might say at the end, I spoke to the consultant and whatever. So yeah, they're definitely doing a lot of the work that would have been done by doctors, and it's just interesting. It's hard to see how they can have that level of responsibility having only done like a 2-year degree. It's on one hand, it's kind of impressive. Sometimes they do sound like they know what they're talking about, but at the same time, you can see how around the edges there are going to be some people who probably aren't fully qualified to be given that responsibility.
I remember, and this is potentially going to be a little bit inflammatory. Okay. I remember when I was
get your bandages
ST2,
ready.
When I was radiology ST2. I was in the IR control room waiting to do a case. We're doing like the morning huddle, and these two guys rocked up, and we're kind of going around introducing ourselves, and they were like, "Oh, I'm so and so, trainee physician associate." And then after we'd done that, the radiographer said, "So what is a physician associate?" Because obviously this is going back to 2017 or something. So right back at the very start, there must have been like the first cohort. And one of the guys responded with the phrase, "We're basically junior doctors." And that was his like summary to radiographers. So I was thinking obviously I'm at the time I'm a junior doctor myself, so I'm thinking I've been a bit blindsided here. I don't really know how to respond, but equally, my understanding at the time was obviously very vague, even as to what the role was. It was this thing that was from the States, and
they weren't a
plans to
threat
introduce it
back
over
then,
here.
maybe.
Yeah, so that kind of coloured my judgment, because I thought that was kind of that was diminishing my training. For me to at that point have done 5 years medical school, 2 years foundation, CST, and then a year and a bit of radiology, for that to kind of be diminished by these guys who have just come in and saying, "Oh, basically a junior doctor doing this with this title that no one's ever really heard of before." I felt as though that where is the differentiation? So for people now where they're working, they're coming through training and they're having to compete for training experience with the physician associates, I can see how that would make you feel as though what you've done is diminished even further. You can sort of think, well, I'm having to compete for access to theatre time or whatever it might be, or IR theatre time. I want to practice the nephrostomy. I don't want it. Why is this person being able to do it? I can see how that would be very frustrating to work in that environment. But I don't know that was there even any sort of like regulatory framework, or I don't know how it works with indemnity even, or any of that sort of stuff when they first appeared. There was just kind of this job advert that was like circulating everywhere for these 50k a year roles.
I think at the initial, if you remember, they were physician assistants, like they weren't associates at that stage. And I think
that wording's very different, actually.
Yeah, and there's close confusion, and I think there's like this melting pot of all these things coming together, which is just literally now like open Pandora's box. So for me, I'm not an expert in this. Of course, I've looked on Twitter, I've seen the social groups, and like kind of got information from that. But it was kind of, they started off as our assistants, and the premise was that they would take some of these more remedial tasks like TTOs, discharge summaries, cannulations, catheters, venipuncture, and free up time for doctors to be doctors. So because everyone remembers their foundation year one doctor job, you're like, what was the point of medical school? I don't understand why I did 5 years. Yeah, I'm just a ward jockey running around doing this, getting shouted at by the radiologist for not knowing why I need a CTPA. But that was the premise.
Exactly happened to me.
But it's more the case like they were there to be, so we could then clock patients, we could then see sick patients. But then I think people caught wind that, you know what, these individuals could do more. And they may have looked at other models within the NHS where people who do certain roles over time build up their competencies, build up their scope of practice. And when it's kind of like an unregulated environment, you can kind of see where you can go until the book stops, where people start go, wait a minute, this is a bit too much. So we then started to get like more roles within physician associate. We got anesthetic associates. They were meant to like help out with more of the more defined, easy procedures. But that's kind of involving the Royal College of Anesthetics had to get involved recently to put out like a statement about their scope of practice. But I think myself observing from afar with a drink in hand, it's more of a case of that all the issues that current resident doctors, which we now are called, not junior doctors, they kind of got the best end of it. Their pay as a starting healthcare professional is more than a foundation doctor, despite a foundation doctor having to do on-calls and a lot of service provision with extra responsibility. Secondly, the ability of foundation doctors and potentially like internal medicine trainees and core surgical trainees to go to clinics has been diminished because of the amount of ward work that's just getting through, because the NHS is just like going into the gutter. But these individuals seem to go. And then the third thing is like, you do 5 years, I did an extra year for an integrated degree, so did Uzi. You come out and you bear the brunt of this responsibility, right? Like everyone will, if it's hitting the fan, they'll find the doctor like, can you please help, this patient's going off. Whereas I think the fact that the physician associates currently can't request ionizing radiation, nor can they prescribe. So they come, do the fun stuff of the job, which is the training bits, and then give you the remedial task. Like, well, I'm now your assistant. I've become your assistant.
I think that's a careful what you wish for thing, because do you want them to be able to order imaging and prescribe? Because then
that's coming.
You probably have people kicking off saying,
don't you?
Yeah, exactly. So
but that's coming.
I personally, is that
no, it's GMC have said that once they are under the auspicious umbrella of the General Medical Council, which we will not comment on for another episode, But they will then be given the ability to request ionizing radiation. When it comes, they will fall under the ERMA guidelines. Secondly, in terms of prescribing, that's now being reviewed, whether they have to sit the prescribing safety assessment to be allowed to be doing that. It's like I said, the boundaries are not clear, and they're being laid out as things happen.
I think I can see from the point of view of trusts why it's so appealing to employ all these people, because you have trainees who come through and they're cyclical, and they're divided. There's a cohort of trainees for a region that's then divided amongst the hospitals, so you may or may not have enough trainees to staff your rota, but then you have requirements on how frequent the rota should be, so you invariably could end up with like chronic gaps in the rota because of European Working Time Directive and all that sort of thing. So for them, it's like, well, we don't want to employ locums because that's expensive, and they may turn down the shift. But then if we get PAs involved, then we can use them to effectively bolster the rota, to bolster the workforce at that resident doctor level.
No, it's like I said,
that gives them some stability then.
Yeah, it's just the rotational training has been one big issue that the British Medical Association are now trying to address. It's become what people consider like hyper rotational training. You're in, and before you know, you're out. And I think that's caused a bit of an opportunity for these more long-standing healthcare professional members to find a niche that they can stay in the endoscopy unit for indefinite until their job contract ends, so they can be trained up. And I think for like a procedural perspective, I can see, as you said, Jamie, why trusts would be like, you know what, this makes sense for us. Because trusts, I don't seem to understand why people think trusts care about you as your train. They don't care about your training. They have their own. I don't think they do though. I think your educational supervisor does, your clinical supervisor does, you yourself should, but otherwise they have their own like outputs that they are being assessed on by the higher bodies.
The KPIs are not to do with training, are they? The KPIs are to do with service provision.
Yeah, did Mohammed get outcome 4 in his plain film at the end of his ARC? I don't think they don't even know who I am really. But it's more of a case that they have their own interests, and physician associates lined up nicely with what they want to do. Reduce the backlog, get paid for these elective procedures. But I can totally understand why the up-and-coming body of senior medical students who are about to graduate, existing foundation doctors, those who are very clinical heavy in terms of clinics, procedures, like going to theatres and stuff, would just be frustrated. They'd be like, what am I then? Because I thought I was meant to do all this, but I'm no longer doing it. So where do I stand in the whole grand scheme of things?
What is my
where
identity?
it goes? Exactly. Like, and I know there's current litigation being put forward against the General Medical Council about them potentially becoming regulators. So they're now potentially blurring the lines as to their role. Not going to get into that because I do not understand the technicalities of it, so I don't want to say anything that is totally wrong. And then, of course,
no libel.
Royal College General Practitioners have said, okay, where is the scope of practice? Because it's a bit weird. For example, foundation doctors who may take an F3 year can't locum in general practice. Like, you can't do locums in GP, and you can't be a general practitioner unless you're like a GP trainee or post-CCT GP. But the physician associates who have had 2 years of post-graduate training after an undergraduate degree can now see undifferentiated patients in general practice. So people are like, why? Why can't you then let F3s locum? Why can't you let SAS doctors be GPs?
There's certainly a double standard in terms of the sort of regulations and expected standards. I think doctors, we have to accept some of the blame, because I think for for too long we were too accommodating and tried to almost rise above the sort of a dispute and be diplomatic about it. And it is kind of maybe we were naive to believe all of the assurances that, oh no, they're just going to be in support stuff, and it's kind of a Trojan horse. But I think now it seems like the gloves are off, and you have all of these more firmer statements coming out, like these, like the BMA taking GMC to court and so on, and you have all of these strong statements coming out from loads of different bodies, and it seems more coordinated, like everyone's now uniting to try and stop this encroachment on the doctors' roles. But maybe it's too little, too late. I don't know. Trying to put the genie back in the bottle. Yeah. It's refreshing at least to hear some of the pushback now. At least it's nice to know that like some of these bodies do have a spine and are able to like does it speak out about it.
Does it affect other allied healthcare professionals? So obviously, like, you know, nurses can become specialist nurses, can become consultant nurses. You've got consultant doctors. Like
they're probably all
those
like
guys. Surely they must also feel pressure on them. You know, whereas previously we were kind of thinking, oh, radiographers are doing plain film reporting now, and then they want to do CT and MR, but then are they feeling? Then the radiographer is going to start feeling pressure from PAs.
No, I think until it affects your bottom line, you'll watch from afar. And that's what kind of, as Uzi just said, we did. We're like, it's okay. No, there's only 300 of them. It's okay. It's a small. There are assistants. It's okay. Oh, now they're now our associates. Yeah, that's fine. Doesn't mean anything. What is a title anyway? And then before you know it, you wake up and you're like, okay, what's going on? Who's this person in the department? What's going on? I thought this list was mine. And then
the GMC are calling us all medical professionals.
Yeah. The trainees are like, Dr. Howie, I can't get an ultrasound list anymore. What do? I need these outcomes where I can't get them anymore. And I think, as you said, Jamie, the horse is not bolted, it's gone. It's gone and off into another continent at this stage. But it's more of a case that we need to kind of rein in what we have. And buzzword of the century, patient safety. I think that's a critical thing. Like, there's all these anecdotal stories of physician associates not introducing themselves properly, blurring the lines, the undergraduate institutes where they train from potentially not even like addressing that, because with other healthcare it's very standardized what their role is, their regulatory body, what they're expected to do, whereas right now there's this enigma that needs to be fleshed out. But I think it's due, and I'm glad that there's been very vocal proponents of doctors on Med Twitter, on Reddit, all these other social media platforms that have kind of instilled a no, enough is enough. Let's figure out what we've done so far. Because there was the whole thing in the Royal College of Physicians, presidents having to step down because of data.
What's that based on this?
Well, it was a whole amalgamation of things, people saying that data was not presented equally and fairly. It was skewed in the sense that a certain narrative wanted to be played out, and they did what they could to get that going. The Royal College of Physicians' involvements with physician associates, a lot of things, and it kind of boiled over to people losing trust in the current Royal College and saying, listen, we want to change. And I think that's what's really required. So I remember at one stage there was one of the training program directors or head of schools for a radiology training program was a non-radiologist, and that caused a huge
that was Leeds, wasn't it?
It's just
and rightly so. The Royal College of Radiology got involved and said, this is not acceptable. We do not advocate. It should be a radiologist. So Royal Colleges do have a place, and they should remember, in my opinion, who they serve, and that's their members. And now all three of us are fellows, which is very good. But but it's more that they are meant to promote best clinical practice amongst that specialty. And I think it's going to be interesting to, in a year's time, where will the battle lines be drawn?
Yeah, true.
Yeah, it's difficult to see whether it will have any real impact, all of this stuff now. GMC is still going to be regulating them. I think they have changed. They're going to be giving them a different letter or a different number at the start of their...
It'll start with PA.
Yeah. So that's a
prefix.
Good... That's at least a good step, as it were.
So sticking with the controversial topics, something that's a bit more radiology themed now. There was a case that was in the local news a few months back relating to a hospital where we have all trained. And the title was Coroner's Warning as Man Dies Months After X-Ray Misdiagnosis. So, sorry, I had to look there. I wanted to make sure I got it right. So, this is in a regional newspaper. It's not in a medical publication. And essentially, it was a patient with peripheral vascular disease who had a peripheral plain film. There was vascular calcification. I think it was a knee X-ray. There was vascular calcification that was on the X-ray that wasn't highlighted as pathological, or
it's not.
There was no kind of recommendation to do anything further with it. And then he went on to have complications of peripheral vascular disease, amputation, non-healing wound, infection, etc., etc., and then ultimately he passed away. So it went to coroner's court, and they did their investigations, and there was some onus placed on the reporting radiologist for the peripheral calcification, basically saying that if this had been commented on, or if there'd been a comment that was actionable, then there could have been expedited treatment, and perhaps the outcome would have been different. So, it's quite a tricky topic, I suppose, because above a certain age, you will see spots of vascular calcification on peripheral plain films, particularly in diabetics, and if you were to recommend vascular referral for all of those, then the vascular surgeons would be very unhappy. Similarly, if you were to request CT angios off the back of all of those, then the department would be absolutely swamped with lots of unnecessary imaging. So I think that there perhaps should be more onus on the clinical side of things. Obviously here we've only got these snippets of the report that were put into the news article. But I think it sets an interesting precedent, really. I mean, I don't know what your stance is on if you're doing your rapids reporting, your rapids practice, and you see some calcification on a knee X-ray.
Every X-ray positive because of calcification. Yeah, that's how you fail your rapids.
Exactly.
Yeah. In the new format, if you're recommending vascular referral for calcification,
there you go.
And you can cite this precedent.
RCR listening, that's a great case. That's a great case.
It was quite irritating reading a news article. I always find when you're reading something that's written for lay people as a doctor, it's just you just eye roll every sentence. But it's difficult to know here who has less of a clue, the journalist or the coroner, because the way it's just ridiculous to think that it's described as a key red flag that was missed, and peripheral vascular calcification is so common. I've probably got a little bit in my popliteal arteries, and it's not pathological, is it? And it's not even that peripheral. Knee calcification or calcification around your knees is it's not in your feet. So I think it's I hope it doesn't set a precedence, because we do need to be using our clinical discretion and judgment, and I don't think it's useful for anyone if we're referring all patients with a little bit of calcification for like a vascular review. They also sort of make it seem like that was the main thing that was missed that could have stopped this outcome. The patient ended up having complications of their sort of amputation and their vascular disease, but they also had like a non-healing ulcer and chronic like leg pain. So I think it was quite clear they had peripheral vascular disease, whether or not it was reported on the knee X-ray. So. Yeah,
and we don't know what the indication was on the knee X-ray as well, so it could very easily have just been knee pain or query OA even. Like it could have been unrelated to their vascular issues. Obviously, as the radiologist, you only have the request to go on. You don't have all the other information, and if they've not had any prior imaging, then you've literally got nothing else other than what you're given. So I think that the clinical side of it is much more important here, I think, than the imaging side of it.
And I think, it's just the coroner. It just seems like someone whose role it is to actually find a cause and is therefore just looking too hard and trying to have some input when maybe there's no one at fault essentially. It's a bit like in football now, if like the referee like doesn't give a penalty and then it goes to VAR, and then, because that's their job to actually look at it, and they're going to like change the decision or have some input because that's just what human beings do. So I think the coroner here.
I think one thing is that when I read the article, which I thought we could discuss on the podcast as we've got included here, it comes back to what is the purpose of the report? Like, do they want a structured report where we talk about everything we find whether it's clinically relevant or irrelevant, but it's there in black and white, and then it's like, for example, like this, the whole thing of structured reporting versus non-structured reporting. Like I remember in the Rules of Radiology, the really great book, if you haven't read it by the way, it talks about what your role as the clinical radiologist is, and if they want us to become all-encompassing, we will describe whatever we see, then once again you need to read the report, because that cyst, if we've documented it and you've not done anything about it, that's not our problem. We told you. So I think just when I read the news article, obviously it's horrible outcome for the patient, but it was kind of like, okay, what do they want us to do? Is what is considered a red flag on findings? I remember this was raised when it comes to like trauma findings, because there was several trusts I've been to, there've been issues where the clinicians have said, you've not rang us about this problem that we've seen, and you should have rang us. And then we kind of clap back saying, well, you request an image and we report, we presume you read the reports. But they're like, no, but if it's this finding, you should have told us, you should have rang across. And I remember the RCR released a guidelines on these certain pathologies you should ring across. And I think it's kind of like coming back to that of what is a report meant to be.
Yeah, where's the level at which it has to be? It's all about where the bar is for recommending onward management, isn't it? It's all about how is your report going to then influence the management of the patient?
Yeah, I don't know if this is necessarily part of our responsibility, but I do feel like part of my role is to prevent the unnecessary further investigations and prevent unnecessary referrals. So when I'm reporting, I do kind of err on that side, because I think it's better for the system and better for most patients if we're not overly keen in sort of pointing out every incidental pathology. But yeah, it would be interesting to get more detail on this. I just can't see, and also this is the opinion of one coroner. If you took a consensus from a larger number, I'd be interested to see how many of them agree with that coroner. And then also if you spoke to radiologists, if you did that sort of ask the same question to radiologists, I think you'd overwhelmingly get people saying that no, that you shouldn't be. It's not something that is necessarily, you can say, is negligent for not reporting. And I think the radiologists are probably more in a better position to make that informed decision than the coroner, because we have that experience of seeing vascular calcification on every single X-ray. So I'm
curious to see what's changed with that trust. What is now
definitely.
Yeah, exactly. The reporting as well. Yeah,
they'll have had to implement something, surely.
Yeah, someone would have done like a root cause analysis, and now they'll like have like a
they'll probably have an alert code
Yeah.
saying we have noted vascular calcification. This can or cannot be pathological. Clinical correlation is advised. Full stop.
Yeah, correlate for clinical evidence of peripheral vascular disease.
Yeah, it's like the plain film reports for fracture. X-ray cannot definitively rule out fracture. If there is
X-ray can't exclude
CT.
Oh, it's like myelitis. Yeah. I take all that stuff out. Like I was checking some X-rays. Someone yesterday it was a query osteomyelitis plain film, and they said plain film cannot exclude early osteomyelitis. And I was like, just why are you writing that? Like everyone knows that, and if you can't see it on the X-ray, then it's not your role to say, oh, just bear in mind if this patient develops any symptoms in future, like it could still be osteomyelitis. You expect the clinicians to be able to sort of make that judgment. You shouldn't be thinking for them. So yeah, all those disclaimers, I don't know whether they're particularly useful or whether they cover us at all.
We've actually had a customer come back saying people are being a bit too overzealous with alert codes. So that's the other side of it as well. So
for sure. I mean, as someone who has to check teleradiology reports, I can
All right, relax, guys. Let's not fight. We're friends here. Relax.
They're on opposite sides of the battle lines on this one. People just alert. So with teleradiology reports, because a lot of the reports that the external reporters put on their scans don't feed into our internal system, we on like a sort of rota basis have to go through them and sort of action them. So if there's an alert on a telerad report, then we put an internal alert on it and then sort of make sure it gets to the right person. And a lot of the time I reply back to the admin person in the telerad company saying this doesn't need an alert. Like you're saying that this patient may have interstitial lung disease or whatever, and it's the scan that's done for like cough and breathlessness, and this is not time critical. The referrer has requested it for this reason. Why are you alerting this? Like there's no emergency here. So I think a lot more people need to think a lot more critically and use a lot more discretion in alerts for sure.
Yeah, it's alerting. So the main crux of it is alerting for the thing that was in the request. So query appendicitis, yes, there's appendicitis, alert code.
Yeah. It's like people think if they've alerted it, then that's it, that they can't be sued. That's job done, essentially, because it all comes down to defensive practices, isn't it?
Yeah, it is.
Everyone thinks
people
that they
being
are
super defensive.
Yeah, and I just think it's a race to the bottom. So I am going to die on this hill and going to be that one voice of reason.
So
not alerting anything. Quarter require.
The specific one so my particular situation was if there's a CT head that is just like a really like a triage request, like the classic thing of an older person who's on edoxaban and they've had a fall, query bleed. And there's that's like the bulk of CT heads that come through A&E, isn't it? Like the majority of the requests are
fall,
for that
elderly,
so it's just they've come in, the paramedic has given the triage person the presenting complaint, and they've been like, okay, well, CT head guidelines, we need to get the CT head, so find someone who's got the access to be able to request the CT head. So then if you were to see a bleed that had like mass effect, if it was to be a significant bleed, are you now telling me that because there's like, oh, it said query bleed, so don't alert it?
No, of course. If it's time critical, like if your alert is going to make a difference to the patient outcome, then of course. But to be honest, you should just be calling that through and then not alerting. I'm
listening in to my elders here. I personally am in the camp that like if you're requesting a scan, you should be waiting on the results.
You should report it yourself.
Yeah, I think radiologists should go to the ward and start examining everyone and be like, yeah, let's like
do your own clinical correlation.
That actually happened to me on call. I got told you should come examine the patient yourself if the scan is not indicated. I was like, well, this is not how it works. But you know what? Why not? We can clinically correlate there and then. But it's kind of like I think it's a case of there's a time and a place. Like I agree with the massive. If it's gonna they're gonna cone, you need to ring through. Otherwise, But if you've requested for a bleed, and you're not then actively following up the scanner, you want us to tell you
then that's negligent
Yeah, like we should seal it every trauma or every acute scan, just so they at least look at it. Like it gets to a stage at one trust, we would alert it for the secretary of that referring clinician to then ring the referring clinician and be like, have you seen the scan report? Yes or no? Just so we know it's like, then what we're gonna ring their next of kin and be like, have you informed your loved one of their scan report too? Where do we stop?
It's been so long since I've been on that side of things, but I can't imagine a clinician requesting a scan and not checking the report. Like, could that happen? Like,
well, it happened at the trust I was at previously. The on-calls were different, but there was like a departmental meeting where there was issues. There was like there was like frustrations between the clinicians and the radiologists saying there was a delay because you didn't tell us about this finding. And we're like, but you requested it, and we kind of put in our internal alert codes. What more do you want us to do? Like, do you want a hot reporter sat in your department who opens the door and goes, yeah, fracture on bay 3, patient 1. Like there's got to be a fine line between us doing our job, which is looking at the scan and reporting it. Like, I wonder what histopathologists do. Do they, like, if they see a cancer on their slides, what do they do? Like, do they just alert code it?
They don't. No, they don't alert anything, man. There's no.
I don't think they run to the ward, to the clinic, and be like, "Yo, what's going on?
What's a histopath emergency?" I don't know.
Not finishing at 5 p.m. That's the histopath.
Oh, you're annoying.
I can say this. My dad's a histopathologist, so I can say all this.
True. Yeah. Nice. Well, from radiologists being too defensive to maybe some radiologists not being defensive enough, I'll move on to the final story with that. So, yeah, I thought it'd be interesting to talk about this story out of Belgium, so going international now, where a hospital suspended their entire team of radiologists due to concerns about the quality of their reports. So it's a hospital in Belgium. I don't know whether I would have thought that the Belgians were pretty professional and good at what they do, but evidently not. So basically clinicians noticed that there were a lot of mistakes on reports, so they did like an internal audit, and they found that in over around 1,000, so they looked at 1,300 exams and found 24 serious errors. And that was deemed grounds for suspending the whole department, which seems a little bit extreme, especially if you do the maths, that works out to an error rate of around 2%, which we're told is basically acceptable. So, and it was like misfractures and misaneurysms and maybe mismeasuring tumours. Phil McCoobie would say that you shouldn't be measuring anything, so that's definitely a contentious point. But so just a bit extreme, maybe a bit clickbaity, but just suspending an entire department of radiologists just seems a bit.
It was
extreme.
infiltration by a tele-rad company.
Yeah, or maybe an AI company.
It's a false flag. It's a false flag.
Look at all these error-prone humans. You don't need them. You can use our.
Yeah, exactly.
Our software never sleeps, never makes any mistakes. Yeah. So, what do you think? It's a bit harsh.
Yeah, I think that. I mean, obviously, it depends on. Does it depend on what the errors are? I mean, they said serious errors, didn't they? So I presume that I think we're talking about like missed tumours or missed fractures or something like that. But even I think that if you were to look at any department in the UK, then your error rate for serious misses would probably be in that region anyway.
I think it may be causing
maybe depending on the sample size, but yeah, I think. Yeah, maybe
it calls into
1%
question.
Is probably like.
Yeah, I mean, for them to go from sort of having this department full of rogue radiologists making all these errors, but just like getting away with it, and then them all being suspended, I think it's like questionable clinical governance. You would like to think that there might have been some interventions before it got to that stage. Like, do they have real meetings in Belgium, or is that not a thing? Are they doing their?
Do they do any peer review?
Yes, are they reflecting enough? Probably not reflecting enough in their annual appraisals. So yeah, it seems a bit more.
No, it seems like it just went from 0 to 100 real quick. There's no in between. It wasn't like, oh, well, let's have a period of introspection. It went, no, you're all fired. Like, did they think about day one post entire department going like the poor trainee who walked in the next day saying, "Yo, is anyone here?" Like, it's like, no, it's you. You're now a consultant. Step up. But
like the Marie Celeste, just like half cups of coffee on the table, like a sandwich with a bite out of it. Like, you get out.
Tumbleweed just flowing across the department. But it's maybe the physician associate stepped. Well, that's another. But it's more of a case of like, number one, like, was it one individual in the department who had a certain higher tendency to overmiss things? Were they all reporting vascular calcification and leading to inappropriate requests? But it just, like, when I read the report, I was like, the meat of this sandwich is totally gone. Like, it's just a nice slice of bread where all these misses, and then the end slice is all of them getting fired. Like, what happened in between and after? But I think it sets a bad precedent, in my opinion. Like, does anyone define what a serious miss is? Is that defined as causes patient harm? I know in UK there is a whole emphasis on learning from mistakes, realm meetings, internal audits, especially within certain subspecialties. For example, breast, there is a huge emphasis on auditing your own work, because otherwise you'll just keep making the same mistakes. Like, you have to constantly get quality checked in terms of your like breast reporting type of things. So I hope this isn't what is the standard over there, because I think you'll just put the fear of God into every reporting radiologist.
Obviously, like, we have AI for certain things, which is supposedly, the evidence produced by the company that makes the algorithm says that it's better than the radiologist. And I wonder if over time what we will see is that there's kind of like less tolerance of errors. So even though you can have a culture of learning from them, will there be more restrictions earlier on? So for example, like, if you miss like one fracture, they might say, "Oh, you missed this fracture. This is where it is." We can learn from this. Learning points. Make sure you check that look at that particular bone on that projection or whatever it could be. And then, maybe if it happens like a second or a third time, then they'll say, "Okay, so maybe you need to we need to supervise you report. We need to double report a load of your stuff when you're looking at whatever the joint was that was involved." But then would they say, okay, well, you missed one, so like we need to jump on it now, and like we need to restrict you, we need to do different, some extra education. I wonder if that bar will kind of come down.
It's a bit like 1984, but in radiology, sort of. It's like quite Orwellian, isn't it?
Yeah.
Like every year you're going to be benchmarks against the AI, and if you don't beat it, then that's it. Yeah. Cool.
So how's life at H3
What's been going on? No, it's I can't really think of anything, to be honest. It's just as business as usual. I've had just done my second appraisal, so 2 full years in the consultant job, and I'd say firmly
very close to retirement.
I know. When I was doing my appraisal, my appraisal was like, so what are your ambitions? Like, what do you want? What are your aspirations for the next 3 years? And I was like, I don't know. I just want to be like just a good sort of regular radiologist. And she was saying like, I need to think of new goals to drive me. That's maybe something I need to do. Think of some more aspirations. What about you, Jamie, in Dubai?
Being kicked out of more conferences?
Oh no!
Oh yeah, no.
Yeah, we'll wait for next year. Yeah, got that to look forward to again.
Oh, so your Dubai conference is going to be lit. Going to be lit.
I know. Yeah. You guys are better be coming along for that one. Strength in numbers.
We'll be about to.
Maybe I should just. I'll put myself. I'll sign up for the RadCast this time. I'll sign up.
No. Don't get us kicked out too.
Turned away at the airport. Giving a call to Dubai immigration.
Yeah, it's unbearably hot at the moment, but
these are the months where you have to stay inside, right? You literally can't go outside.
Yeah. It's so at the moment the humidity is like 80% in the morning and the evening, and it's like 40 degrees. So it's basically like being in a steam room when you go outside.
Jeez.
Yeah, it's very, very unpleasant. But
you were saying before the podcast to switch off your AC.
I know. Well, I would be struggling if I was not allowed to use AC for an hour.
But it's still.
But other than that, work wise, nothing major to report. Like things seem to be kind of going along nicely. I've got the plan kind of. Because of how the summer is over here, everyone leaves, so summer's a quiet time. So that's been my time to kind of plan for the next. It's almost like a school academic year, like September to June. So plan the calendar in for the next phase really.
Still enjoying the telerad stuff. Still finding it stimulating. All those 4 a.m. trauma scans.
Do you need goals?
Do
you need goals as well?
Do you long that MDT? That interaction with the orthopods?
No, I'm very, very happy with the subject matter of my clinical role.
Do you not miss being reminded that your workplace competencies are expired in manual?
You still have to do an appraisal. You still have to do it. You can't.
Yeah, I mean, I did. Yeah, so I do have mandatory training, but it's nowhere near as extensive. I don't have to do like venipuncture. What is it? Transfusion rules or whatever, like all the other stuff. Antibiotic guidelines.
The fire alarm safety guidance. Oof. Uzi will tell you it's gone up a notch.
Yeah, so I don't have to do any of that. But I do have some mandatory training that I have to stay up to date with, and I do still have my GMC appraisal, which I had in June. I think you have the same appraiser 2 years in a row, and then it changes. I think that's.
Is it only after? I thought it was for a whole cycle.
The rule. Oh,
I don't have a. Is your by GMC appraisal is that the same as my trust appraisal? Is it? Am I meant to have a GMC appraisal? Okay,
yeah. So I have my appraiser's brilliant. He's a retired GP / public health physician who he does appraisals full time. Not just medical appraisals. He does appraisals for like Apple and Microsoft.
Full-time appraiser.
And stuff. Yeah, and then he's also like medical director or responsible officer. He's got some role with a private company that does cataracts in the UK. So he's a very interesting guy. Yeah, and he's really good at doing appraisals. I find it very, very, very valuable.
Really.
Well,
yeah, I find it quite tedious.
It's not a tick box exercise. It's not a formality. It's really enjoyable. Yeah, it's good.
That's a word for it. Okay. So
I've never heard anyone so excited about their appraisal.
I'm like, I'm meeting John next week.
Jamie tweeting just with John.
Before we sign off, so the last thing we want to just announce is that we did the third running of our anatomy competition a few weeks ago. So that went off very well. Had 150 or so entrants, which was I think like 50 more than the year before, so it continues to grow very impressively. And we've announced the winners, so that the winning candidate knows has been awarded their prize. So that's well done to them. I think their name is Aishwarya. I think they I recognise them from maybe some of our other courses as well. So they're a RadCast committed
alumni.
RadCast alumnus. Yeah, and it paid off for them in this anatomy competition. So yeah, really good.
Yeah, congratulations!
Yes,
amazing score, by the way. Yeah, very good
score. I think that was probably better than episode 1. So
wait till I've edited. Wait till I've edited. Then we'll see.
So we'll wait for the edit, and fingers crossed it will look as good as I think it's gone. So thank you guys. Good to catch up with you again. We got through some meaty topics there, some nice debate, which I'm sure everyone will appreciate. So thank you very much, and I'll let you get back to your weekend.
Until next time.
Thanks for listening, guys, and episode 3 will happen at some point. There's plenty to talk about.
Thank you very much. See you later.
Bye.